Hello, welcome to case-based learning of cardiac MRI on mricardiac.com. Middle-aged male with abnormal PET-CT findings was suggested cardiac MRI for further workup. The main clinical complaints were breathlessness. He was otherwise clinically well preserved. There was no history of deep vein thrombosis. D-dimer levels were normal. CT scan had revealed this lobulated filling defect in right main pulmonary artery, and it was showing increased uptake on PET-CT scan. So hence the diagnosis of pulmonary artery sarcoma was considered, and cardiac MRI was suggested for further workup. So as we see over here, these are axial spin echo black blood images. There is lobulated filling defect in right main pulmonary artery. It is centrally located, solitary, does not extend into distal branches or main pulmonary artery, and it is showing restricted diffusion on the DWI images. Post-contrast images reveal heterogeneity with mild post-contrast enhancement, as we see over here. And there is also evidence of delayed hyperenhancement on the LG images. However, on the high TI values, the lesion does not remain dark, unlike clear thrombus, and it is showing heterogeneous enhancement, as we see in this case. T1 and T2 mapping values were elevated, and it shows beautiful depiction of the lesion. So in view of this increased uptake on the PET-CT scan with hypermetabolic uptake and this abnormal cardiac MRI findings, the diagnosis of pulmonary artery sarcoma was confirmed. So it is a very rare tumor and which presents as a filling defect in pulmonary artery. It is important to differentiate it from pulmonary thromboembolism because imaging findings and clinical aspects may be similar in both the cases. The lesion can be either intimal or intramural, and different pathologies like leiomyosarcoma, chondrosarcoma, osteosarcoma, or undifferentiated tumor can present in this case. Clinical symptoms will be non-specific, just like chest pain, dyspnea, breathlessness, rarely hemoptysis. The symptoms are usually with shorter duration. There will be no evidence of deep vein thrombosis, and there will be normal levels of D-dimer. Initial workup is usually with CT pulmonary angiography, and MRI and PET-CT scans are second line of investigations. So to few imaging features which help to differentiate it from the pulmonary thromboembolism, the most important is the contour, with bulging lobulated contour with some nodularity on the surface will raise the possibility. It may show some heterogeneity and intratumoral vessels or some post-contrast enhancement. The lesion is usually single and more centrally located. There could be some amount of lung ischemia as well. There are different types and pathologies which could be seen, such as diffuse or wall thickening. It could be cauliflower or polypoidal lesion, as was seen in our case. Rarely, it could be just mimic an impacted tumor, and it could be also present tubular or polypoidal shape. Few important diagnostic features which may raise the possibility of this tumor would be: one would be the broad-based attachment to the main central pulmonary artery, and as well as the acute margin with the vessel wall, as seen in this case. The wall eclipsing sign, as we demonstrate over here, is very classical in sarcomatous etiology rather than the pulmonary thromboembolism. Here, as we see over here, the lumen is completely occupied with this low density mass, and there will be a protrusion of the proximal end of the mass with eclipsing of the wall of the MPA, RPA by this lesion. So this wall eclipsing sign is not observed in thromboembolism, and it is one of the very specific signs for sarcoma. MR features will show some heterogeneous post-contrast enhancement, and on higher TI values, the lesion will not remain dark. So thrombus will remain dark, and any of the neoplastic lesion will not remain dark. That is one of the differentiating feature. There will be high signal on T1 and T2 weighted images with some restricted diffusion. You may find some pericardial or cardiac involvement. Most importantly, there will be increase in thrombus size in spite of anticoagulation. You may get some pulmonary nodules because of the secondary metastatic spread. The lesion will be moving with the cardiac cycle and may involve the valve or the RVOT. Usually it is an expansile mass and with some amount of heterogeneity and extraluminal extension in most cases. Similar concepts can also be found on our book Cardiac MRI Simplified. For any feedback and suggestion, please mail us to info@mricardiac.com. Thank you.